Here we are. Welcome to London, guys. Welcome to London.
All right, so I use IVUS in 100% of my venous cases, of course, 80, 90% of my arterial cases, and I highly recommend that if you want to start using it, get your staff used to it. Now it takes 2-3 minutes to do the IVUS between pulling it down to the table and getting everybody familiar. My staff actually does the measurements for me. So these are my disclosures. Let me show you a case first. This is a case of a non-healing ulcer with triple vessel obstructive tibial disease. You see some islands of tibial reconstitution, and antegrade crossing was unsuccessful. We want a retrograde, use the rendezvous technique through an 014 microcatheter, then basically used a specialty balloon, then drug-coated balloon. That was 4 years ago at the time when we thought it was going to be helpful. And we ended up with multiple dissections through the vessel. And the question for you right now is, what do you do next? In terms of which dissection are you going to treat, if you can look at the angiogram carefully and tell me which one of those 5 dissections you think require further treatment.
Okay, raise your flag if you treat A, for example. Consider treating A. Raise your flag if you consider treating B. Raise your flag if you think about treating C. What about D? And what about E? E could be also an artifact, from what I see. But like it's interesting. Okay.
So literally the statistics of the room say that almost 20% of people pick different dissections. There's no consensus on that. There's a lot of interpretation, a lot of experience. So to walk you through that, basically what we do with balloon angioplasty, 80% of vessels that have been treated with angioplasty, we know, have a dissection. That's how balloons work. So having dissection is not a problem. We still rely on the angiographic definition of dissections, which is archaic from 1985, and it counts on if there's wall staining, if the wall staining is spiraling around the vessel, and if there's a vessel occlusion, and we classify that from A to F. But the problem with this classification, it's a coronary classification. Back in the days when we used to do plain balloon angioplasty in the coronaries, and it's very old. There's no real correlation between the severity of from A to F versus clinical outcomes. And it doesn't account for the length of the dissection, the depth, if it's affecting the media, or the circumference of the dissection. So for that reason, Dr. Shamas has published a new classification, which will hopefully be applicable on different levels once the data start piling up. This classification relies on if the dissection affects the media, yes or no, and what's the overall arc of the dissection? Is it 180 degrees plus or less? So those 2 factors only. So you have to train your eye on looking at the media itself. In A, there is no dissection to the media, and it's classified A1 and A2, depending on if it's 180 degrees or not. In B, the media is involved, and in C, it's a deep dissection that almost gets to the adventitia.
Hady, well, I mean, please convince me to use this classification in the case you have shown before. Because I think this is very useful if you have like a spot, like in a coronary with short segment. But in a case like before, do you think it's applicable or not?
I do think it's applicable depending on experience. So the issue is knowing if the media is dissected or not. If you get this only one factor, I think this correlates with clinical outcomes, because you can have a non-flow limiting dissection that we leave alone, that we sometimes treat with drug-coated balloon in the FemPop segment, but it's affecting the media and it closes up in 20 minutes while in recovery. And you can have the opposite. You can have sometimes a spiraling dissection that's very superficial, that is clinically non-relevant. So we really need something else besides our angiographic assessment of that. But to apply this throughout the entire course of the vessel requires experience. But if you pick one of them and you're really not 100% sure, this is where IVUS can help you. Just focus on that spot and tell yourself, am I going to treat this or not? So this is what a media dissection looks like. This is the hypodense area below the intima that looks discontinuous, that doesn't have any continuity. That tells you that this part of the vessel is actually needing more help. So why IVUS? Let's start with 3 questions. What is IVUS? Why do we use IVUS? And when do we use it? In what kind of cases? What is IVUS? There are different kinds of IVUS. Most of the IVUS that we use these days are phased array IVUS, which means that the circumference is lined up with ultrasound emitters that will give you a picture right away versus the traditional rotational IVUS. And obviously, each one of them has pros and cons. The downside of the phased array is the wire artifact. You have to ring down. But at the same time, it's much faster, and it's much more accurate, and it's much deeper than the rotational one. It gives you literally a histological definition of the vessel. This is obviously almost a normal vessel. So it gives you a lot of information. This hypodense area in the middle is the media. The intima is obviously more medial, and the adventitia is a thicker tissue, deeper than that. It also gives you information that will help your intervention. So in calcium, it's not only the vessel is calcified or not. When you see it on fluoro, you see that calcium on the fluoroscopy before the angio, but this one gives you one level higher than that. Is the calcium superficial, intimo, like you see on the panel on the left side, where it's literally against the lumen with the attenuation artifact, versus if it's medial, like you see the calcium on the third panel, where you can see it very clearly with shadowing below it, or is it adventitial? So why is this important? In this panel A, I would use atherectomy, rotational orbital atherectomy. In panel D, I would use intravascular lithotripsy. This is whatever I do on the lumen, I'm never going to touch that calcium. So it does have clinical implications. I'll give you many examples of what this looks like. Does anybody have a laser pointer that I can use? No?
No, but you can walk that, you can show us.
Pardon?
Why don't you go there?
All right. So the fibrofat, this is mostly a fatty plaque. You can see the hypodense heterogeneous aspect. This is a fibrous plaque. Obviously, it's hyperdense, but you don't see any shadowing behind it, and it's well defined. The calcified plaque is the most hyperdense tissue that you see with shadowing behind it. And thrombus is usually heterogeneous. It has irregular borders, and it does not have a shadowing artifact, especially red thrombi. So based on this, you can make much better clinical decisions. So in this lesion here, in the popliteal lesion, you see that it's a subocclusion. You don't know what's in there. It could be a stent restenosis. It could be intimal hyperplasia. It could be thrombus. None of those actually you can guess by angiography. But you can decide to put a distal protection device if you see a thrombus. You can decide to use cutting balloon angioplasty if you see intimal hyperplasia. You can decide to either use drug-coated balloon or reline it if needed, if it's neoatherosclerosis. So this all changes based on that versus just looking at a subocclusion going in with a balloon. Secondly, vessel sizing. You can see by angio, this vessel looks like a 6, 6.5. By IVUS, it's almost 8 millimeters if you go from media to media. Traditionally, we go from the external elastic lamina to external elastic lamina. So this will definitely change the sizing of the devices that you choose. Why do we use that? Now, the data has been accumulating. This is a prospective study that compared angiography alone versus IVUS plus angiography, and there was a significant difference in the binary restenosis rate and in the clinical outcomes. This is a Medicare registry database that has included almost 500,000 patients between 2016 and 2019, And basically, you can see that in real-life cases, where 17% of these cases had intravascular ultrasound, the major adverse limb events have significantly decreased by 2% or 2.5% absolute risk reduction, which is massive in the world of amputation. And this is a meta-analysis. The first one was a registry. This one is a meta-analysis of multiple studies that have been accumulating the data on the favor of IVUS with regards to increasing primary patency and decreasing the percentage of major amputations. The angiography is discordant with IVUS with regards to vessel size, length, the percentage of stenosis, the presence of calcium, how much calcium, plaque morphology, and dissection identification. You can see on the panel on the left side, it's a 30% angiographic stenosis. By IVUS, it's a 75% stenosis. The types of disagreement between IVUS and angiography is close to 45%. That's almost half the lesions that you treat. In terms of length, also the same thing. We land our stents in diseased areas, which lead to restenosis, versus landing it in a clean segment. IVUS and DSA disagreement with regards to sizing is mostly important in tibial vessels. As all of us have seen this morning, a lot of tibials look like 2.5 and 3. And most of the time with IVUS, you add 1 millimeter to that.
How many people ever inflated a 5 millimeter balloon in a tibial vessel? So why did the other people why did they not do it? Because probably you're scared about the size. I mean, I'm not saying I inflate a 5 millimeter in every posterior tibial artery. Also, this is what I like to show. Sometimes I put these cases on LinkedIn because, I mean, some vessels really allow you to push with a 5. If you undersize, you undertreat. All right. So
absolutely.
Essentially, this is something that is so important. You know, the size of the vessel. Try to, even if you use IVUS, try to correlate the IVUS image also with your angiographic image to understand better, to resize, to reset your scale. Am I right?
Absolutely.
Theo, what do you think about this?
Just
Or
clear, though,
Craig?
For those of us feeling a little bit impotent now, most of you are going to be sizing with IVUS, aren't you, before you stick a 5 mm balloon down.
Can we have the microphone open, please? Can we open the microphone to the, yeah? Craig? Okay.
I'm saying for those of us feeling a little bit sheepish about not putting a 5 mm balloon down a tibial, I'm assuming that for those who've done that, that's post-IVUS measurement, isn't it?
I mean, it depends. Personally speaking, like, because if you use IVUS once, you size your vessel, so essentially...
Okay, you get an eye for it.
If I know this is a meter, okay, I know this is a meter. But if I say, no, this is not a meter, the meter is that much, then I try to also to rethink about the size, my angiographic size. Because, I mean, everything we go with a standard. If we change the standard, then we change all the measurements. This is what I noticed by doing the Supera stent a lot. I was oversizing my balloon, looking at, that's not that bad. And so that's why I try to resize all my vessels also.
So the question is, which is the proper modality to size a vessel like a tibial vessel? Because we know that, for example, for the aorta, if you do ultrasound, we underestimate versus the CT scan. So which is the best modality to size a vessel in the leg? That's the question, because otherwise...
You see, I take the bias of being an interventional cardiologist. IVUS has proven itself to be life-saving in the cardiology world, and the way we measure that is the external elastic lamina, the difference between the media and the adventitia, and to the diametrically opposed segment. So that's in the entire cardiology experience how we base vessel sizing, and this is the one that's associated with the best clinical outcomes. Of course, in the peripheral world, we still have to see those data. I showed you a few studies, meta-analyses, registries, but it's not enough. It's upon all of us actually to kind of prove that, because it makes sense and it's the best for our patients.
Can I just have one comment? I mean, I get your point about the 5 millimeter and the PT, but for the surgeons in the room who do distal and alterdistal bypasses, how many patients have you explored their posterior tibial artery and you found it actually 5 millimeter in diameter?
Talking about the proximal, I'm talking about proximal and posterior tibial artery. I'm not talking the very distal lateral plantar, of course.
Another critical point is very interesting, but At the moment in Italy, we don't use IVUS, and we treat a lot of tibial arteries with good results. So probably it's a balance of two things. We are used to use 3.5, 4 millimeters, and appear enough at the moment. You suggest 4, 5 is something very complicated.
Yeah.
I mean, the thing is, what I've seen, I can tell you from my very recent practice, there was a posterior tibial artery, like let's say the common plantar artery, very distal posterior tibial artery, which was dilated by another operator with 2 millimeters. Okay, I inflated a 3.5 shockwave balloon, and if you look at the size of the vessel, it's perfect. So if we are at a time where we inflate a balloon of 2 millimeters in a vessel which is 3.5, then that's where we're wrong. Because I think that we are giving 50% of blood flow plus recoiling is going to be occluded again. So this is why this patient went from a single first toe amputation to a transmat. And the patient came back because even the transmat was not healing. We did a 3.5 and now the patient is healing. Single vessel runoff. So I think this is where, I don't think it's a matter of, if you want to, take it like by big numbers of 3.5 to 4. It's a matter of 2 to 4. Because many people I've seen in this country, I've seen around, and I've learned from other guys not to dilate the tibial vessel with 2 millimeter balloon. But when I did the webinar, during COVID, a surgeon said my interventional radiologist did a fantastic job, dilated the whole anterior tibial artery with a 2 millimeter balloon, and then it unfortunately went down. It's not unfortunately. You can't dilate the whole tibial artery with a 2 millimeter balloon. I mean, apart from very rare cases. So it's impossible. So that's where we need to focus. We need to focus in trying to go away from the 2 millimeter balloon and to try to move, between 3 and 4 for the proximal and between 2.5 and 3 for the distal. And many people I know, it's not a drama. I was not doing that too, but many people don't do it. So that's why it's our message. Try to size the vest correctly and think about 2.5 and 3, even below the ankle, and think about 3 to 4 in the proximal. In occasional cases, you can go up to 5. It's not like a sort of provocation, It's not like a...
Can I just ask for the non-IVUS users in the house today? Red flag is the reason. Availability, red flag. Green flag, cost. And the yellow one is like...
Time.
Your skepticism. Availability.
Stefano.
Right, so I remember very good comments from Dr. Semetsky last year after his presentation about IVUS. I think that we had to clarify because he's a cardiologist, so he knows very well the algorithm in the coronaries, and probably he likes to do the same for peripheral. So if the title of this presentation is infrainguinal disease, probably what we can do with IVUS, so with duplex, is everything up to the popliteal. So it's cheap, it's safe, and we know also the flow. So we can measure the arteries, we can check the plaque. Of course, we have the shadow, but we can, if we have shadows, we can measure the diameter before and above and lower. So in my eyes, we can do everything with IVUS except for BTK. So these suggestions are very good for BTK, in my eyes, if we have to save money, of course. Otherwise, we can use IVUS for every case, because, of course, we could have some benefits. But the proper sizing, if this is the issue, so I think that there is another way to assess the final result, is the flow. And you can check the flow, so from monophasic to biphasic to triphasic flow with the duplex, so with the IVUS, is something more. So my personal suggestion is do it just for BTK.
I would say also the other vascular bed where there's a major advantage of IVUS is the iliacs, especially with regards to perforation, confidence of the operator, type of technology you're going to use. Of course, angiofluoroscopy gives you some estimation of the calcium for IVL versus not. But in terms of perforation risk, you are almost certain that you're choosing the right type of stent and the right size. If you need.
You want to say something?
Yeah, I want to say, my comment is that
I think in UK, I don't think we have got that luxury of using IVUS for every case, so certainly we don't. But I think those who have the luxury to use the IVUS may be worth measuring the healthy vessels or patients with diseased vessels to rename them. We may be under-treating, that's what Lorenzo is trying to say. I think obviously it will be very nervous to treat with any 4 millimeter balloon or 5 millimeter balloon into the tibial vessels. Maybe 3.5, but I think I don't know whether anyone has done any published any study saying that, okay, we have done IVUS in 100 patients, all tibial vessels at this level are 3.5 to 4, and at this level, so there must be something there. We don't need to do IVUS to measure the size on every individual patient. That will be not costly effective, in my opinion. So I think people who have the study, the luxury to have used the IVUS in tibial vessels, why don't we get together and publish the tibial vessels, resize the whole thing, and see whether that actually make a different measurement. Because when we operate, we really don't see that big vessels in the distal tibial fold. I mean, that's what I think.
Prof. Torsello, quickly?
Yes. How should we choose the size of our balloon? That was your question. And what is the most important measurement we should do? Because you know from the coronary that we have also a positive remodeling, so the adventitia can be very, very thick, and the vessel diameter is something different from lumen diameter. So how should we choose, and what level of the vessel should be our reference for the choice of the balloon or the stent?
Really an excellent question. It comes up in clinical practice. You're IVUSing throughout the vessel, and you're seeing all kinds of things. What I would say is go to the least diseased segment adjacent to your lesion, where you think you can make a media, you can actually see a media, and that's where you measure. It could be sometimes 5 centimeters away from your lesion. You just have to look for it. And sometimes the entire vessel is just super diseased. You have to count on your knowledge and your experience from people with the same size. And so a man, usually a 4 millimeter tibial, a woman 3.5. Below that, you're going to have all the bad outcomes we had for BTK studies. So I would say the closest vessel that's the least diseased would be this measurement.
Because this explains also the problem sometimes of the people, especially in Japan, who make their measurements of the vessel and not of the lumen.
That's right.
Because we don't want to squeeze the plaque down to the adventitia, but we want to preserve the lumen. This is our with the stent or with the PTA. And if you oversize too much your balloon, you have, of course, more problem. One example was the eminent, not the eminent, the drug-eluted stents. They saw a lot of aneurysm formation or degeneration of the vessel wall if they use the IVUS, but the IVUS, doesn't make this, but induce to use devices which are much larger.
Absolutely.
I would like to ask one question. When you do IVUS measurement and IVUS measurement, and for example, if you measure the IVUS vessel measurement, it comes at 4 millimeter and you dilate it. Did you often see the patient is experiencing more pain, or they are?
If you size 1-to-1, usually not, unless there's a calcium spicule that you're really trying to stretch at high atmospheric pressures. But if you size 1-to-1, according to the media, usually.
So you measure from IVUS media to media.
Media to media, correct. From external elastic lamina to external elastic lamina. And we're fortunate all these companies have tremendous inventories of pictures and images and cases, and so they can support our education with regards to how do I measure, how do I do this, how do I do that, and they make your life much simpler.
And Michael, the last comment?
We have to continue, Lorenzo.
Mike Zia, Dallas, Texas.
So I'm still a little confused. That was an awesome anterior tibial artery result, and you asked everyone what should they treat. What was the answer, and how would you have treated that lesion with the dissections?
Yeah, so
Exactly. That you remember that.
right.
Yeah.
So basically, the one, basically on angiography, you wouldn't be able to, but by IVUS, the one that I showed you, where the media is actually dissected, that's the lesion that we treated. So that's why I was presenting this case to show the discrepancy and the lack of...
What did you do? Did you treat all of them? Did you treat some? Did you treat...
I treated only one of them in the proximal segment with a drug-eluting stent, a coronary drug-eluting stent, but the rest of them, it was either TAC, self-expanding stent, versus more aggressive angioplasty. Sometimes you can go up 5-minute angioplasty, but the most proximal one that didn't look that bad actually was the worst.
Should we go to conclusions? Because I mean, like, we really run out of time.
Yep. So obviously the only thing that...
Go. In the meantime, I say it's something that we should dedicate an hour to, but like it's...
right.
Also the time is always constricted, but it's a very healthy and nice conversation about, pros and cons. And, you can see many things, of course.
Just before I think this one is the most helpful, intra-procedurally, IVUS-based re-entry. You can see the needle so nicely. You're puncturing at 3 millimeters. You get your pioneer exactly where it's supposed to. And this is an external iliac. I would never do that just based on feeling or the Outback device. This is 100% guaranteed. You're puncturing there, you're seeing your needle, and you see it. So I hope you can get some experience with that.
No, I think it's like if there's something if you want to achieve something, we need better training anyway. Because I think what you said is key. Just to know where the media is, it's already. And I know, like also my experience, I started using IVUS pretty recently. Many of us wouldn't tell where the media is. They can't read the image. So I think we need more training and more, understanding of what's happening, and probably we can achieve better results. And I thank you, Hady, for that.
You.
Thank you for your talk.
Thank you.